bit, I'm going to show images of the third adult type diffuse glioma, an oligodendroglioma. Oligodendrogliomas are tumors arising from precursor cells and mature into cells resembling oligodendrocytes. They are located cortical and subcortical with a predilection for the frontal lobe, and they often have calcifications. Oligodendrogliomas can be grade 2 or grade 3 and then are called anaplastic oligodendrogliomas. Oligodendrogliomas grade 2 often have some enhancement and increased RCBV, so the enhancement and perfusion cannot be used to discriminate from the grade 3 oligodendrogliomas. You can use diffusion-weighted imaging, where the high-grade tumors are more cellular and therefore have restricted diffusion. The enhancement and increased RCBV can be understood if you look at the histology. Oligodendrogliomas have a honeycomb pattern of tumor cells and in between them branching vessels with a chicken wire pattern, and this intensive vasculature explains the enhancement and increased perfusion. They also can have hemorrhage, calcifications, or microcysts filled with mucin. In 2016, oligodendrogliomas became one of the first genetically defined tumors. So you needed to have not only histological an oligodendroglioma pattern, but also two mutations, one P19Q deletion and an IDH mutation. Before 2016, it was said that the 1P19Q codeletion occurred in over half of the oligodendrogliomas, so then it was a prognostic factor. The reason that the 1P and 19Q often occur together is that before this deletion, there's a translocation with the 1P19Q chromosome that gets lost in the further steps. And because this codeletion that was a prognostic factor first became part of the definition, it's not a prognostic factor anymore. In 2010, it was described that all gliomas with 1P19Q codeletion also have an IDH mutation, so that's also part of the definition. If you change the definition of a tumor and make it a molecular defined tumor, there are tumors that were previously called oligodendroglioma that become astrocytomas now because they do not have the 1P19Q codeletion. There was an interesting article in 2017, so 1 year after the WHO update from 2016, where they made the oligodendroglioma a molecular definition, and they looked at the imaging features, and 1P9 codeleted oligodendrogliomas have indistinct borders, whereas astrocytomas that microscopically have oligodendroglial features are more sharply demarcated. So if you would like to predict on imaging the molecular status, the ill-defined border can be helpful. In 2016, there were still oligoastrocytomas, and for oligoastrocytomas, the same thing happened as with oligodendrogliomas, and they started looking at dividing them in 1P19Q codeletions and oligoastrocytomas without this deletion. And also in the oligoastrocytomas, the 1P19Q was an important predictor of progression-free and overall survival. So there were already some neuropathologists proposing that we should get rid of the term oligoastrocytoma and choose between either oligodendroglioma or astrocytoma. But to do that, you do need to do molecular diagnostics in all cases. In 2021, this was effectuated, so since 2021 there's no more oligoastrocytoma, only an oligodendroglioma 1p19q, and if it's not 1p19q codeleted, it's an astrocytoma. Tumors are not only defined by the tumor cells, but also by the tumor microenvironment, and we already talked about that a little bit when we talked about the IDH in the previous vlog. And this is an article from 2017 where they looked at IDH-mutant oligodendrogliomas and astrocytomas. And because this is such a colorful picture, you cannot see the microenvironment very well. But I've made this picture gray so you do not get distracted by the tumor cells. And they looked at tumor cells from 16 patients and bulk tumor from 165 patients, and they found that astrocytomas have more macroglial cells and macrophages, and oligodendrogliomas have more neurons in their tumor microenvironment. And if you advance in grade, there's an increase of macrophages over macroglial cells. And the tumor microenvironment is also very important for the prognosis and the therapy. And if you look at this scheme, it has become very complicated nowadays. And we do a lot of imaging in tumor follow-up. So in the next vlogs, I'm going to talk about perfusion imaging and post-treatment gliomas.